Good morning. I want to thank you all for having me speak to you this morning about a topic that I am passionate about. Having worked on informed consent and been an author and developer of FDA's guidance on informed consent, which I don't know whether you all know, that just published a couple of weeks ago, and it's in draft form and available for comment. And we would love to have you all take a look at it if you wanted to do that on an individual basis or as a group and provide feedback, because some of the issues that we're addressing today, we touch upon in that guidance, particularly issues related to literacy and numeracy and how to handle research participants who are physically impaired and other such matters. So I would encourage you all to please take a look at that and to give your educated feedback to FDA as it thinks about finalizing that document. And before I begin, what I'd like to do is just tell you what my conclusions are, so that will help frame your understanding of my talk. And I think that, and I'm pleased to see that some of the conversation that we've already had, we're starting to develop certain themes. At least I'm going to echo some of the topics that we've already touched upon. And one of them is that I think we need to have a multi-pronged approach to improving the informed consent process and to learning more about it. And I think that we need to continue to acquire evidence-based information and do evidence-based empiric research on informed consent. I think we need to educate the public and potential research participants not only about the informed consent process, but more generally about what clinical research is and what their role is in clinical research, the benefits of it, and how they are an important partner in the research endeavor. And I think thirdly, we need to partner better with, and more extensively, with patients and disease-based foundations and advocacy groups. So I think that those three, is what I would suggest as something that we can continue to talk about, and I'm sure that some of our speakers today will embellish those themes. But I see that those three areas as being key. And part of what I'm going to do is unpack that a little bit more as I go through my discussion. So first of all, I'm not going to go through the basic components of informed consent. Jeremy's already taken you through a discussion of that. The reason that I have this slide here is to explain that I think, as Jeremy has already articulated, that it's not just disclosure or understanding as being the crux of the informed consent process. There are a lot of complex learning activities that go on in informed consent that I think, besides the subjective piece, which I think impact the quality and the success, if you will, in quotes, of informed consent. And so I think that we need to bear that in mind as we think about how to improve informed consent. And I think that we, in fact, need to have research on all areas, empiric research on all areas of the various components of informed consent. Clearly, as Jeremy mentioned, we have largely focused mostly on understanding. The second slide I want to put up to sort of set the stage for what we're talking about is the complexities of studying informed consent. And there are many others who are going to speak today who've actually done research in this area. So I'm just going to touch upon a few of the topics. And then I think that besides the fact that informed consent is a complex array of learning activities, clinical research itself is diverse. We've already heard that mentioned, and in survey research is very different than first-in-human research with an investigational product about which we know very little. And does that, and we've already started to think about whether that should impact how we handle the informed consent process. And I think that merits more discussion, but I think that it ought to in certain important ways. Study populations are different. How does that affect what they might want to know? And then data derived from various informed consent studies to date are very heterogeneous themselves. So how we interpret that data, we've already had a wonderful presentation looking at some of the literature, and we've heard this addressed just a bit, and that is that the setting, the timing of when we ask people questions about the informed consent, whether it's immediately after the process has been completed, whether it's 2 months later, what types of data, the quality of the methodology used, and whether or not that data can be generalized to other groups is someone who's gone through multiple clinical trials as part of their cancer therapy, different than someone who's novice to the research setting and so forth. So I think that we ought to not only bear in mind how complex informed consent is itself, but also how complex the data is that we have and the data for acquiring more information about informed consent. But my topic was really to look at what are some of the considerations when informed consent does not work well, and then I was asked to provide some information about what are some of my suggested solutions, if you will, and to touch upon information sharing, which is a pretty daunting task for 20 minutes, but I'm going to try and do that quickly. So I think that there are some practical concerns that we have if informed consent is not handled well. Many of these are pretty much intuitive, that the failure to describe the nature of the research and the scientific reasons for it could potentially affect recruitment. There are some who say that perhaps recruitment isn't affected, and that's why we can have informed consent functioning as poorly as it does in a sense, and still have a bevy of patients who are willing to be part of the process. How does it affect retention? I think that's a really, really interesting and important question that I would venture to say I have not seen much on. We don't tend to do what we call exit interviews on patients who decide, and participants, research participants who decide to leave the research context. They are now, have withdrawn consent. Do we ask them, what was it about the research that made you leave? Was it the informed consent process itself? Was it a disconnect between your experiences and what you learned through the informed consent process? And we particularly don't ask people who decline to participate in research, why are you not doing so? It would be really interesting to know, after they've gone through an informed consent process, whether that changed their minds. Did they come to the clinical context thinking they were going to be part of the research, and after they went through the informed consent process say, this is not for me, and why? So I think that there are ways that we can get more information about recruitment and retention, and it would be important to do so. Long and complex forms may inhibit reading and processing. We're all familiar with how we just click that we accept when we get a Google app on our phones and we don't read the terms of agreement and feel overwhelmed by that kind of information. Certainly, long and complex forms may increase resource burdens in reviewing the documents at the IRB level, increase burdens in drafting the documents, and could potentially delay startup times, particularly when you have multiple sites all editing various aspects of the informed consent documents. Now, I have heard a number of people already say that they think the regulations are largely to blame for the long and complex informed consent documents. I would actually argue against that. And the reason I would argue against that is because we've actually had these regulations in place since the early 1980s. They grew out of what the National Commission thought would be ethically acceptable disclosures and ethically important disclosures in informed consent. And over time, you've actually seen, and Paul Applebaum and others have done this research, the growing length and complexity of informed consent documents since the regulations were put in place. And the regulations have not changed. It's how they're being implemented that has changed. And so and if you, again, Linda had mentioned that you don't need to disclose everything that's in the regulations. There's 8 basic pieces of information that need to be disclosed. 6 others that have to be disclosed when appropriate and as applicable. And then there's the piece on clinicaltrials.gov, which is not applicable to every single trial. So I think that the regulations, I would argue, and we can discuss this further, are not the key issue. They're not the key driver to the complexity of informed consent documents themselves. And again, I say that the interpretation of them by those by the stakeholders who are implementing them might be that in order to avoid, as Jeremy said, being dinged by the federal authorities, they go way beyond what the regulations might require. Moreover, the regulations do state that the informed consent documents have to be, and the informed consent process has to be in language understandable to the research participants. And in the guidance that I mentioned to you, we actually describe that low literacy and low numeracy should be taken into account when you think about what language understandable to the research participants means. Okay, so other practical concerns with informed consent is that there can be a decreased understanding by research participants of the actual study procedures, and that may in fact influence data integrity. If they're not following the protocol-driven procedures, they may actually affect the outcome of the data. And so too might their reporting, if they have of adverse events, if they have a misunderstanding of what the purpose is of the research. If they're enrolled in a phase 1 study that's more so looking at safety, and they think that the trial is really there as a treatment trial, they may perhaps underreport adverse events. So in looking, I too changed the title of my talk a little bit. And I said that it's impact of poor informed consent processes on clinical trials from the practical to the sublime. So I've given you a few, I think, pretty intuitive concerns from a practical standpoint. And I'd like to look at what are the aspirational goals of informed consent, some of which Jeremy's already covered, so I won't dwell on them, and how those might be affected by a poor informed consent process. Well, we talked about honoring self-determination. We frequently think of autonomy as an expression of, informed consent as an expression of the principle of autonomy. But we are also trying to empower, or we should be trying to empower the potential participant to decide whether the risks and benefit ratio is acceptable to that individual and whether it remains acceptable throughout the course of the research. So you can also, I think of informed consent as an expression of beneficence and non-maleficence in that regard. You want to respect the potential participants as true partners, and you want to maintain an ongoing dialogue. A lot of information and research about it and thought is given to informed consent prior to the initiation of the study. But informed consent is a process that should carry through the entire study and possibly afterwards. And I would argue as well that research participants, at least what I've heard anecdotally, are very interested in at least getting aggregate study data, not just sort of saying, you've come in for your last blood draw, goodbye and good luck, but to continue communication about how was the research important and what did we find, and that is a way of honoring their role throughout the study. And then, of course, what we're not going to talk about much today is that tailoring the informed consent process to those who are with diminished autonomy or decreased decisional capacity is one form of protecting them. So failure to provide contextual meaning. So I think that one of the concerns that grows out of our inability to achieve the aspirational goals is that we fail to provide contextual meaning to the informed consent to the process and for the individual. And I actually noticed that in your the IOM report on low numeracy, Brian Zickman Fisher said, the goal is not just to recognize the number, but also to draw the meaning they need from the number to make the choices they need to make. And that's what I'm talking about here. We've already heard others mention the idea of meaning in the informed consent process. I think that when informed consent is handled poorly, it fails to engage participants as true partners and may lead to their sense of objectification or commoditization. And then it can, of course, promote distrust and anger. So those are the concerns that I think that occur with handling informed consent poorly. And I think that we've already, a couple of the slides that I wanted to present is on the idea that, and Jeremy already expressed it, that we should not just go with our intuitive thinking as to what will be beneficial to improving the informed consent. We really do need to think about and study those intuitions. And the next few slides I will leave for you to review at your leisure in the interest of time. But one of the points that I'd like to make is, given the complexities of studying informed consent, we ought to think about nesting informed consent studies in real research. And what I mean by that is, if you're doing a cardiovascular study, can you build in an informed consent study as an ancillary study to that research so that you actually have real-world data on informed consent rather than simulating certain informed consent projects. There's some really interesting research that was just presented by Deborah Schrage, who's at the Dana-Farber. She presented it last week at the SACHART meeting. And what they did was they looked at what improving the informed consent process within the context of palliative chemotherapy. And what they found was that people did not want the informed consent organized by drug. They wanted it organized by regimen. And they wanted people to tell them, how is this going to affect me? Am I going to be able to drive when I'm taking this chemotherapy? Am I going to be able, do I have to be hospitalized, et cetera? And they wanted to hear real patient voices as part of the informed consent process. What can I do to combat my nausea? And what have other people said? And they actually put together a booklet with lots of pictures and quotes of real patients. And they are now going to test this booklet in their population. And I thought that that was a really interesting way of thinking beyond the informed consent document. The NCI did something similar with revising its template, and I think that during the discussion period, we might be able to discuss that a little further. But one of the things that they found is that shortening and simplifying their document, when they tested it with colorectal cancer survivors, not research participants, there was little difference in the satisfaction between the longer and the shorter template. But what did come up is that people who were familiar with clinical trials were actually more inclined to want to be part of clinical research. And I think that goes back to one of my points, that if we start educating people about what clinical research is about in a larger community-wide basis, that we may have a contextual framework for people to understand information given to them within the informed consent process. So the next several slides are going beyond the informed consent document, going beyond the individual, and reaching out to other disciplines to help us learn how to do informed consent better. And that's all part of your materials. Finally, to conclude, on information sharing, I think that we are about to embark on a hugely challenging area of research. Jeremy's already talked about comparative effectiveness research and sharing data across large healthcare systems. I think that sharing big data, how we do that, and what people want to know about how their information will be used and who it will be disclosed to, as well as how biospecimens will be used and for what types of future research, is going to really challenge our thinking about informed consent. And I've given you some references. And just to conclude, I want to emphasize the need for public dialogue, education coupled with evidence-based research on informed consent. Thank you.